Hello, and welcome to our podcast, 2025 American College of Rheumatology Guideline for the Treatment of Systemic Lupus Erythematosus. Guideline summary. We record these podcasts for you every month, so you'll always be able to keep to date on the latest literature and expert opinions. My name is Professor Ed Vital. I'm a professor in translational medicine at the University of Leeds in the United Kingdom. And I'm delighted to be joined today by two of our expert faculty, both of whom have worked a lot on treatment guideline development in the past year. So one of them is Professor Maria Dall'Era. She's the Jean S. Engelman Distinguished Professor of Medicine and the Chief of the Division of Rheumatology at the University of California, San Francisco. And Dr. Guillermo Pons-Estel, who's a leading specialist in autoimmune diseases at the Centro Regional de Enfermedades Autoinmunes y Reumáticas, Grupo Aroño, Rosario. So hello, I hope I pronounced that okay, and welcome both.
Thank you so much, Ed. It's wonderful to be here.
It's a pleasure to be here, Ed.
So, the 2020s, the early 2020s is proving to be a time of a lot of guideline activity, isn't it, for SLE? So there's been updates to EULAR, ACR, GLADEL, lots of national guidelines, and there's updates on SLE guidelines and on lupus nephritis. And the reason all this change is not just because we don't know what to do, it's actually because there's lots of new evidence and there's a lot of repositioning of therapies. And I think the guideline that you've been working on, Maria, really has, I suppose, tackled some of those difficult issues, it would be fair to say.
Yeah, so thank you so much, Ed. I think this is a wonderful time to be talking about all of these various guidelines that are in development, some that have been published, and how we can put all of these together as we think about managing our patients living with lupus. And so I can speak about the 2025 ACR guideline for extrarenal lupus. The publication is not yet out yet. It is forthcoming, but the guideline summary is online. And so I'll be referring to that guideline summary as we go through this presentation today. And you'll see a slide that has the high-level points as well for those of you who are watching this video. But perhaps I could just give some foundational concepts that might help understand how to interpret the guidelines from the ACR. The first thing is that the ACR uses what's called grade methodology when they do their guideline development. And this is a formal process by which the evidence from the literature on various therapies is graded. The quality of the evidence is graded based upon very specific factors. And at the end of the day, the quality of the evidence is rated as either high, moderate, low, or very low based upon specific factors. And from that level of evidence, we then come up with the recommendations, either a strong recommendation or a conditional recommendation. And just a few other points to make here is that the ACR guideline is applicable to children and adults with SLE. We included 7 manifestations, and these are hematologic, neuropsychiatric, mucocutaneous, serositis, musculoskeletal, systemic vasculitis, and cardiopulmonary. The core leadership team consisted of adult and pediatric rheumatologists plus 1 dermatologist. And then we had a separate voting panel. The core leadership team were not on the voting panel. The voting panel were adult and pediatric rheumatologists, dermatologists, a rheumatology physician assistant, and importantly, there were 2 patients living with lupus on the voting panel. There was also a separate patient panel, 13 patients living with lupus who met separately, and their decisions and their thinking informed the voting panel. And 2 of those patients on the panel sat on the voting panel. So a very close collaboration between patients living with lupus and those physicians who were on these various panels. So I think that's very important just to just to put up front. And the last kind of foundational principle I wanted to state is that only 3 of the recommendations in the document are strong. The rest are conditional. And that's important for all of us to understand what that means. What that means is there's a lot of room for shared decision making with our patients. For a conditional recommendation, the benefits and the risks aren't exactly clear cut. Many people would choose the recommendation, but many people would not. A lot of gray area, and that's because we don't have rock solid evidence for many of these recommendations. And so I think this gives us a lot of freedom to engage with our patients to make the right decision for the patient in front of us.
Okay.
And so with that background, we can just go through some high level, I think, points here from the guideline. In terms of goals of management, we are emphasizing treat to target. And this is a theme that is coming up frequently now in multiple sets of guidelines. And that is that we should be targeting either remission or a low level of disease activity. We want to make sure that we reduce morbidity and mortality as we take care of our patients, and also minimize treatment-related toxicities. And this theme is also the concept of disease modification, which many of our listeners may have seen as well, that this is another concept that we're putting forward in lupus. Some of the recommendations.
Kind of the idea that as we have more treatments available to use, then the targets should get a little bit more ambitious in terms of disease activity and steroid minimization.
Exactly. That's exactly right. Because now we have targeted therapies and other therapies available to us. So we should be able to hopefully begin to reach those targets. Exactly. So we can decrease damage progression, improve health-related quality of life, improve mortality, all of that. And so in terms of just some high-level recommendations, I'll just start us off and then we can kick it over to Dr. Pons-Estel. But to begin with, for monitoring, there are 2 recommendations, and that is to assess disease activity regularly, including when there's a change in clinical status or when we're changing medications. That's very intuitive to all of us who take care of patients, but that is one of the recommendations. Also to assess disease damage at least annually, again, so we know where we're headed. We know if we are impacting progression of damage. In terms of treatment goals, as I mentioned, a goal is optimal control of disease activity, and that means remission or lupus low disease activity state. Glucocorticoids should be used to obtain rapid control of acute inflammation, but it's important to use the lowest dose possible for the shortest duration necessary. And then importantly, to initiate immunosuppressives and immunomodulatories early so we can minimize glucocorticoid toxicity and get that dose down. In terms of some specific recommendations around glucocorticoids, we recommend that for organ or life-threatening disease, pulse methylprednisolone should be used, and then start with a lower oral dose of glucocorticoids. And for all of our listeners out there, this is also what we recommended for lupus nephritis. If you remember this notion that we use pulse methylpred up front, so we can use a lower dose of oral glucocorticoids and hopefully a more expeditious taper at that time. And then recommend a taper of prednisone to less than equal to 5 milligrams a day within 6 months. And importantly, try to get that dose down to 0. And that's also a theme that we're seeing, right? That we don't want our patients just to stay at 5 milligrams a day in perpetuity, but we need to get that dose down because even very low levels of glucocorticoids will cause toxicity. And by the way, this is one of the 3 strong recommendations from the guidelines.
Actually, that's interesting because when I did the British guideline, that is lowering to 5 enough, or do you really have to try hard to go below 5 and get to 0 was one of the most debated points, actually, interestingly. There were some people thinking that if you try too hard to get rid of that last 5 milligrams, you might be making people ill unnecessary for doses that aren't that toxic. And I don't know, I kind of think it depends how long I mean, yes, maybe if you've been on it for 10 years, but ideally you wouldn't get into that situation because you'd have a more planned taper at an earlier stage. So that wouldn't arise.
I agree. And we had a very heated exchange over this as well, that exact issue. And there were some people on our core team and the voting panel who I think, and some of the patients expressed this opinion as well, that if we drive down that glucocorticoid dose too low, as you said, Ed, I mean, people can flare. And then the question is there more potential side effects from piling on too many immunomodulatories versus just keeping people on a low dose of glucocorticoid? And that's so challenging because we know that even doses of 2.5 milligrams a day of prednisone will lead to trabecular bone loss in the spine, for example. We know there's a slight increase in infection. But I love the point that you made that if we can get to a point in time where we don't have people on these low doses of steroids for 10 years, if we can just use steroids, we
if it was only ever used for the first month or 2 months or 3, and then you tried to get them off early, then you wouldn't be it. Yeah, exactly. But yeah, it's always interesting when you do a guideline that there's always a large amount of it everyone basically agrees on, like more or less. And then there's like 1 or 2 things where someone wants to walk out of the room. They disagree with it so much. So it's always the fun.
It's always the fun, exactly. And these are all very, experienced people with different opinions. And it speaks to the fact, right, Ed, that we don't have the perfect randomized controlled trials that give us the data to answer all of these questions. And so we have to do our best with the data that we have and also our clinical experience to put forth the guidelines. Right?
And of course, yes, you try to achieve consensus, and sometimes you can, and often you can't get exact consensus. But then, of course, science doesn't usually work with consensus between experts. Normally, experts disagree with each other. And also, guidelines are actually meant to be flexible in practice. We never say to them, your doctor must do exactly this. It's always up to the specific scenario. So trying to even make them so precise may not be worth it anyway.
Absolutely. I always like to state that guidelines are not mandates. They are guidelines. And especially with a disease entity such as SLE, which is so heterogeneous molecularly as well as clinically, we have to have that ability as a physician and a patient to work together to make the best decision for that person in front of us. And so I completely agree.
And so some of, actually, again, the British one like I've been doing is just one thing I found was that some of the most interesting bit is in the little narrative that you write about why it may be this in some scenarios or that in another, like what we just said about steroids. That kind of where you give the nuance can be as valuable as the, why this versus why this can be.
Absolutely. Absolutely. And I just have a couple of more comments, and then one more comment that one of the other strong recommendations is to treat with hydroxychloroquine unless contraindicated. That's not a surprise to anybody. And the last thing I just want to quickly mention in just for a couple of seconds here is I think it's important. We had a separate patient panel, as I mentioned, and we learned a lot from listening to what our patients with lupus have to teach us about this disease and their lived experience with their disease. And they were an instrumental part of this guideline process. And I just wanted to mention a couple of highlights for me. The patients time and time again mentioned the pill burdens of trying to take complex medical regimens, specifically with oral medications. Do I take it on an empty stomach, on a full stomach? How do I time this during the day when I have a busy work schedule? How do I deal with that? So that was a theme that came up time and time again. And then they also mentioned the importance of shared decision-making. We've been speaking about that treatment goals have to align with their values. And they mentioned the importance of a collaborative team approach, especially when thinking about various, organ-specific manifestations, dermatology colleagues, nephrology colleagues, cardiology, et cetera. So the patients living with lupus were a very instrumental part of this whole process.
Yeah, and that last point, I think I was very conscious of that too, that we don't just talk about SLE overall anymore. With the more therapies we have, the more we have to think about different organs in a different way and different specialists. Okay, so at that point, maybe that's a really good point for me to hand over to Guillermo, because you've had experience on your own on the GLADEL guidelines, and both in that one and in the ACR one, there's a bit more of an attempt to go into granular detail on the different organs and features, isn't there?
Yes, in GLADEL is working together with PANLAR, and these are the Latin American guidelines that also are going to be published at the end of this year. We have a granularity, so we touch system by system, and I think it's more or less what Maria and the core group on the ACR has done. So I know that they have covered hematological manifestation, neuropsychiatric manifestations. There's a lot of debate on mucocutaneous because we have more information on that side. Serositis, musculoskeletal, where we also have systemic vasculitis and cardiopulmonary manifestations. I know, Maria, that you have said that in many of these recommendations, most of them are conditional. So what can you tell us about the experience, for example, in the ones that we have more information, such, for example, musculoskeletal or skin disease?
Yes, it's very interesting because, as you just said, Guillermo, even in the manifestations where we have more data, as you said, in the skin, for example, or in the musculoskeletal organ system, even there, all of the recommendations are conditional because there was a lot of debate and a lot of patient preference and values that came into that. And the other thing I should state here is that even though there's a lot more data for, let's just say, the targeted therapies, those therapies were put into a clinical trial with a mixture of all sorts of patients, right? So we didn't just study patients with arthritis. We didn't just study patients with rash. They were all mixed in. And so that lowered the quality of the evidence, quite frankly, as the voting panel was thinking about the grade methodology and how to rate all of these, because we didn't have those organ-specific trials. And so that also downgraded to very low evidence and conditional, as you just said.
That is one of the problems. And we had, again, on the British guideline, we had exactly the same challenge, that we wanted to give more detail because now in some sense it was actually easier for us to give more detail because we were writing our guideline for one country that has a single healthcare system for everybody. So that actually lets us be more specific about some things like how the referrals should happen, how the follow-up should happen, when they should see a nurse, when they should see a doctor. So that shaped a bit of our approach because as you say, you haven't got the evidence that certain drugs are correct for different organs all the time. That isn't what things look like. But so we pulled out certain things where we thought it was important. Like for the cutaneous disease, what we tried to flesh out is a bit like this kind of stuff, see your rheumatologist. If you've got a scarring lesion or something on your face, or you need intralesional therapies, here's where you need to go to a derm. We tried to describe that a bit more about how that relationship works. Similar for the nephritis, about why you need both specialties and what their jobs are. And then for the other stuff, there were just a few. We didn't try to describe all the organs, but we said things like, if you've got HLH, it's a different treatment based on anakinra, etc. If you've got neuropsychiatric, maybe the belimumab, anifrolumab, etc. data isn't quite so applicable because it tended to be excluded from the trials. And all similar, maybe similar for the severe, some of the hematological things where rituximab starts to come up a bit higher in the actually grade of evidence. So we sort of did stuff like that.
It's interesting, in our guidelines, we did exactly the same. And we know that in many of the manifestations, and there are many other manifestations that are not covered by any of these guidelines, not the ACR, not the EULAR, not the GLADEL-PANLAR, or the British. So you have this type of rare manifestations that there are some recommendations that have come, I think, from one of the professors from here, from Lupus Forum, that have done a great job by Lauren Arnault on rare manifestations. So we know that we cannot cover all with these guidelines, and there's the problem of access. For example, giving this point of view from undeveloped countries, such as countries in Latin America, there's also always the thing that you have to make a guideline for different countries who have different access to care, who have different healthcare system. So this is also another barrier when you have to come out with a guideline and a recommendation. And this is why, as Maria said, many of these recommendations are conditional recommendations. So we are giving the choice of different physicians to have different type of plans on how to treat these patients when you have access or when you don't have access to some of these new drugs.
And I think what you raised there is another point that I think all the different guidelines where people have slightly struggled with it a bit. It's just, okay, we've got newer therapies. They have good evidence, targeted therapies, they've got good evidence for them. They're higher cost. And it does raise questions about kind of that sequencing. I found in EULAR very, very difficult. So what are we saying? We're saying bring in the best drugs early. Makes sense because lupus is bad in year 1. So don't hold back your best drugs. But then again, are we also saying that, does that mean don't bother with all those conventional immunosuppressants we used? And I don't think anyone really knows the answer to that question, isn't it? Like, do I give one immunosuppressant and then go to a biologic, or none, or two, or we don't know.
I totally agree. None of these guidelines are going to give the answer to that. So it's the share decision with the patient, as Maria said, what we have access in each of the healthcare system. So I don't think that we are going to have the answer, at least not for in the next few years.
And so often at each point of therapy, the physician who reads it could be still offered quite a considerable choice of what to do. Couldn't they? Like, it's not like rheumatoid where we're pretty clear that you go methotrexate first, then something else. We're not actually in such a clear position, are we? You'll always have a choice, and it needs to be nuanced. And that actually made me think of another point I thought, which is that you can write the guidance, and some of it's stronger than others about what should be done. Some of it's clearer than others. But how do you know it's actually going to be followed? Yeah. Well, how do you get the implementation to happen? That we've said some of these decisions are difficult. That makes it sound like in some situations you need to see someone who's more specialist, more focused on lupus than others. How do you make sure that happens? How do patients even know what they should be offered? So there are some patients who don't know that there are some other options out there for them, and so that's another interesting challenge, isn't it?
Totally. For example, in the Latin American guidelines, one of the pillars of the recommendations is delaying diagnosis and early diagnosis. So related to that, the type of immunosuppressors that we can give to the patients, the early is the early that they're going to be treated, and the early they are going to be treated are patients who usually don't have damage and who are usually not so overexposed to glucocorticoids. So I think that's one of the things that most of the guidelines have to make a stronger point on this early diagnosis. And this comes to what you have said, the referral to the rheumatologists, mainly at the diagnosis, and then how to work with internal medicine and primary care physician to follow up these patients that have a lot of comorbidities that most of the times in the consult we cannot take care about as a rheumatologist, and we have to work together with them. This is one of the strongest points that we raise for example, in the Latin American guidelines.
Yeah. Maria, did you have any thoughts about that with the ACR guidelines, the implementation phase?
Absolutely. And there was a lot of discussion around this. And I think, in the United States, there are many issues and problems right now with patient access to specialty centers. And I think when you look at these guidelines and you see the multitude of choices, right, for each of these disease manifestations, as we just said, Do I do conventional? Do I do a targeted biologic? Do I do both? There are a lot of options at this point in time. None of these recommendations are prescribed recommendations. And how does one, if you are a general rheumatologist, not specializing in lupus, how do you keep up with all of that? So I think ideally, being able to have that patient in a specialty center that is experienced in taking care of patients living with lupus and has that special expertise, I think is the most beneficial for that patient. However, access is a huge issue, at least in the United States, and trying to get to the specialty centers. Even a center like mine, I will reveal to you that if you go through the normal channels of a referral to our specialty center at my university, it is a 10-month waiting list for a new patient. Unacceptable. Totally unacceptable. How can we give patients the care that they need? So we try to find ways to, of course, get patients in earlier. But we're having a problem on that end. And this also raises the issue of many of the disparities that we see in the United States, where people who live in more rural areas, not near academic health centers, or in rural areas where there are no rheumatologists, that's where people tend to have major problems in terms of, Guillermo, what you just said, delays of years in diagnosis. So I think that we have a lot of work to do in trying to improve the care of our patients, access to specialty centers, support these centers. But then also, I think the point that you made, Ed, was very well taken in terms of how do we put the word out and educate our patients living with lupus about their options so they can be advocates for themselves? How do we reach them? How do we do that education? And I think that is also one of our major responsibilities.
Yeah, I think so. I think that's patients can take control of quite a lot of this, potentially, given the right information. And then there's this issue that because lupus is a less common rheumatic disease, it's how do you manage the relationship between a general rheumatologist who treats all specialties and somebody who's more dedicated to lupus? And that's what we felt was defining where we felt those boundaries lie. Like, this is the point at which you should be interacting with a more specialist center. This is the point where you don't need to. This is the point where a dermatologist, a nephrologist, or a neurologist needs to get involved. These are the issues where defining that can be quite useful on both sides, actually, both for the person, the referring rheumatologist, and the specialist center. Another thing we leaned on quite heavily, maybe this works better in our healthcare system, is that there's quite a lot of, you can shared care between different centers in different ways. So you go to your specialist center this often and your local center that often, and there's an online MDT to discuss difficult decisions rather than taking over the entire patient. So every Friday I'll do a forum where my local hospitals will discuss certain situations and we'll make a statement but not take over all of the care, or say we do want to take over the care. So I think these issues are getting more acute, aren't they, as the guidelines get more complex and the options get to be more complex. But as I'm always saying on these podcasts, that's a good problem to have, because it means you've got lots of choices. And that's probably about all we have time for today. So thanks very much, Professor Maria Dall'Era and Dr. Guillermo Pons-Estel.
Thank you. It's such a pleasure to be here, and thanks for the opportunity.
Exactly the same. Thanks for the chance to be here with you.
It's great to hear all your thoughts on these developments, and thank you to everyone for listening. You can, as always, find a slide deck related to this summary at lupusforum.com. So that's a PowerPoint that you can download, use for your own teaching and presentations. And the Lupus Forum is always free to access. All of our content is free to download. If you're not already, if you could register for updates on the Lupus Forum, you'll get emails every time something new becomes available. And you can follow us also on Lupus Forum, all one word, on X or on LinkedIn. So thanks again, and see you next time.